I think I'll start with Dr. D'Souza. We've got some pretty sophisticated questioners here in that a recent clarification of the complete hematologic response criteria have just been published. And the question is, does the definition extend to include individuals who have myeloma and amyloid, or just myeloma? And what are the hematologic response criteria in patients who have impaired kidney function?
Wow, that's a really great question, and indeed very sophisticated. I think as we have gotten better at having more sensitive markers of determining how the cancer clone is doing, our definitions of responses have evolved over time. So for example, in multiple myeloma, to say a patient is in CR, we not only have to look at the SPEP, the electrophoresis and immunofixation in the blood, we also look at free light chains, and we also do a bone marrow biopsy, and we have to document that there is less than 5% cancer in the bone marrow. In amyloidosis, thankfully, we don't need a bone marrow to show it. We go completely by the blood panel and blood and urine tests. So if a patient has normalization of their immunofixation result, so no M spike, and the free light chain ratio is normal, we focus more on the difference between the involved and the uninvolved free light chain. So before we used to look at just the ratio, but recent data have shown that if we can bring that difference down to very low levels, and again, that number keeps changing. Earlier, we used to think that under 40 is good enough, but now there are data that show that if you bring it under 20, under 10, I think it will, the lower we can get these numbers to, the better it is. I think another important part of response is this MRD, or minimal residual disease measurement, which is a test done in the bone marrow or using more sophisticated and sensitive markers of looking for those cancer cells, either in the bone marrow or in the blood. And we are still learning how to use them and how to, whether we should be making treatment decisions in the clinic based on this MRD assessment.
Thank you. Dr. Liedtke, in terms of all of these response assessments, it's light chain, light chain, light chain. What role, if any, does serialized measurement of imaging, bone marrow, echocardiography, cardiac magnetic resonance imaging in terms of monitoring patients going forward?
Yeah, I think we've focused a lot so far on talking about the hematologic response, and it's definitely been observed in the context of studies that the deeper the response, the higher the chance of an organ response. But ultimately, I think what our patients care about is their organ response and is how they clinically feel. And on the organ response side, we've traditionally looked at biomarkers. Like Dr. Maurer pointed out before, we're looking at NT-proBNP and at the decrease in the level of the NT-proBNP to assess a response. But we don't grade the organ responses the same way we grade the hematologic response. On the hematologic response, we talk about a partial response when we fight back the disease by about 50%, and about a very good partial response when the difference between the involved and the uninvolved light chain is less than 4 milligrams per deciliter. But on the organ side, we really only have either you have a response or you don't. And there's an ongoing effort that's led by the Mayo Clinic to grade organ responses as well, so that we can not only say somebody has an organ response or doesn't, but we can say somebody has a partial organ response or a complete organ response, because that makes a difference. And that is initially at least also going to be mostly based on biomarkers, but the biomarker may not always reflect the functional status of the organ. And that's where things like, imaging study or echocardiography comes in, where we can actually see a change in the actual organ function and not just a change in the biomarker. The other thing that would be really interesting for us to have, of course, is a measure of how much amyloid is deposited in the body and in which organ is it deposited. And our European colleagues have SAP scintigraphy for that purpose. That's a technique that can be used to image the amyloid deposits. And you can follow a patient over time and see whether the deposits are actually cleared out of the organ. SAP scintigraphy is not approved by the FDA for use in the US, but there are other PET-based techniques that can take its place. And so over time, as we're able to achieve better hematologic responses, we'll have a need to also grade our organ responses and define them by imaging as well. That's work in progress, and that's definitely going to be happening over the next couple of years.
Fortunately, we have Dr. Jonathan Wall with us today, who'll be giving us a presentation later. Although he is, by definition, European, I think he's currently a native Tennessee volunteer. Dr. Karam, can you tell me how you assess patients with amyloid nerve issues?
Yeah, so once the diagnosis is already made, we usually take a history, ask the patient what's bothering them, if they have symptoms in their hands or their feet, numbness, tingling, burning sensation, or weakness, tripping on their feet, trouble getting up on the stairs, getting up from a chair. If they're having lightheadedness when they're standing up, if it's severe enough to cause blackout, if they're having constipation, diarrhea. In men, very frequently, they develop erectile dysfunction. And, we have to ask them and we have to treat that because usually men don't volunteer these information. And so these are mainly the symptoms that we ask for. And then, of course, we do our neurological examination. We may do nerve conduction study in EMG. We may do autonomic testing and some other blood tests, and then we treat the symptoms.
Thank you very much. Now I'll turn to some of the easier questions for Dr. Paner. I don't know if you're familiar with this COVID-19 virus I've been hearing about. There are questions now about what your policy is with vaccination and what you're doing if they're on DARA or after a stem cell transplant. Will the vaccination have any impact on the measured endpoints in amyloid? Can you give me your current policy, Dr. Paner?
Well, so thank you for that question. I think COVID vaccination is a key issue all aboard. And we follow ASH guidelines that we do recommend vaccination to our patients with hematologic malignancies. Even though these patients didn't participate in the clinical trials with the vaccine that led to FDA emergency approval, there is no reason to think that they would have worse side effects from the vaccine. There is no live virus, not even attenuated virus in the vaccine. It's just a piece of genetic material. I think the only concern I had is about how hematologic malignancy patients will mount the response to the vaccine. How effective is it going to be? Is it really going to be close to that 95%? We know that in myeloma patients don't quite respond to influenza, to flu vaccine or pneumonia vaccine, and yet we still recommend those vaccines. So to all patients here, yes, I do recommend, along with the Hematologic Society, to get vaccinated for COVID, whether you're on a treatment or not. The only caution is for patients who are right after transplant. We wait 3 months to vaccinate. There is some concern maybe on a treatment with Daratumumab response to vaccine could be too diminished. And it's hard to make sense of what would be optimal time of scheduling. And I think with all the complexities in scheduling, I just recommend my patients to get the vaccine regardless of where they're at with Daratumumab. My suggestion is usually the sooner the better.
Thank you. Dr. D'Souza, how often are you monitoring light chains in patients on treatment? How often do you monitor light chains in patients off treatment and observation? And talk a little bit about the variability, the reproducibility of the light chain results. And when do you start getting nervous about what constitutes progression of disease?
Yeah, so in patients who are on active treatment, I do check free light chains once a month. In patients who have taken a break from treatment or in the observation mode, I try to get them checked at least every 3 months. In some patients who have been stable for longer times, we might extend it out to 4 to 6 months. I do run into a lot of trouble, a lot of questions regarding free light chains. I think it's the bane of every hematologist, seeing these minor fluctuations. If you have had a cold in the last month or 2 months, light chains can go up. If you have been sick from other reasons, stress can also sometimes make light chains go up. So I try not to overreact with just one abnormal reading. I try to recheck in a few weeks' time and make sure that it is indeed a true change in free light chains and not just a lab aberrancy or due to an acute illness.
Thank you. Dr. Maurer, in patients with cardiac amyloid, how often are you checking the biomarkers and how often are you checking the echocardiogram? And how often do you do it in patients who don't have cardiac amyloid?
Yeah, so I think similar to what Dr. D'Souza described, we check biomarkers concomitant with light chains usually every 3 to 6 months. I would point out there are probably more fluctuations in your NT-proBNP than there are in your light chains. If you eat a pizza or some Chinese food, your light chains can go up quite a bit from volume overload. And so I think it has to be put in the clinical context with regard to what are, significant changes. Also, concomitant worsening anemia, renal dysfunction, all make your light chains, your cardiac biomarkers, particularly your NT-proBNP, go up. And there are a class of drugs, particularly the IMiDs, that despite lowering the light chains can raise your cardiac biomarkers, which is always a confounding factor. As people indicated, we tend to focus a lot on patient symptoms and their cardiac biomarkers because they're much more responsive to clinical effects. We do check echocardiograms. I would point out that in the old days, we used to use a surrogate of amyloid load, which was wall thickness. That's clearly fallen out of favor because if you don't have your echocardiogram read by the same laboratory consistently over time, any major changes in wall thickness, in my experience, are actually due to a different reader. You're trying to measure the thickness of the wall. You're supposed to be perpendicular to the wall. If you're at all off axis, you can elongate the wall thickness, and that's just an error in the measurement per se. More recently, we've used measures of what we call cardiac mechanics. These are particularly measures of strain or myocardial shortening that are available in almost every echocardiographic lab. The myocardium shortens as you contract, and the measurement of what we call global longitudinal strain is measured in a negative percent, because the heart is shortening or getting smaller. Normal is usually in most laboratories less than minus 16%, so values of minus 17, minus 18, minus 19. People with amyloid have decreases that are proportional to their cardiac involvements. They could be as low, God forbid, as minus 6 or minus 5%. And a clinical response is not yet defined, but the emerging data seems to suggest that in the long term, measured usually not sooner than a year after therapy, do we see any changes in these parameters, but an absolute change in global longitudinal strain of about 1.5% is considered potentially clinically significant. So I try to be honest, underemphasize the role of echocardiography and its routine measurements in patients in the absence of any clinical progression. If you're feeling worse, then we're happy to repeat an echocardiogram. But I think a routine echocardiography, especially early in the course of the illness, often leads to anxiety that is related to measurement error, not necessarily to factual information.
And so echocardiograms done locally and then at the Amyloid Center, what about the comparability there? Because that happens a lot in centers.
Yeah, and that's the concern. Yeah, I think it behooves you to try to get an echocardiogram done in a reputable laboratory, preferably one, as you're describing, that has experience in amyloid and that can measure some of these, I wouldn't even call them novel anymore, but emerging measures of myocardial mechanics. As we all know, ejection fraction, which is the commonly used measurement myocardial function that cardiologists employ, which is the stroke volume, how much the heart pumps every beat, divided by the end diastolic volume, the amount of blood the heart holds, is notoriously inaccurate and not useful, especially in A, diagnosing people with amyloid, and B, in following the course of their illness.
Can we spend a couple minutes just talking about blood thinners? I'd like to ask your policy both in patients who have heart rhythm disturbances as well as those who don't have heart rhythm disturbances or maybe sedentary. I mean, how does Columbia do this?
I think similar to most places. So a very common rhythm that people develop as they age, irrespective of having amyloid, meaning about 10% of the population over the age of 75 or 80 has a heart rhythm that is called atrial fibrillation. The atrium is the top part of the heart that pumps the blood into the bottom in a coordinated fashion. Bum, 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 bum. Fibrillation is a Latin word. It actually means dancing. So the upper chambers of the heart are just wiggling. And because they're not efficiently contracting, blood can stagnate inside the heart in that circumstance, form a clot, and that clot, God forbid, could dislodge as what we call an embolism and cause a stroke. AFib is more common in AL amyloid than in other forms of cardiomyopathy. In my experience, at least a third of patients have concomitant atrial fibrillation, and over time it becomes more common. We actively survey for atrial fibrillation in our patients with AL amyloid, meaning we not only do what used to be called a Holter, a monitor that you wore for 24 hours, but we now consistently put monitoring devices that are patches. There are some proprietary names. One's called a Zio patch that can go on your skin, could be worn for 14 days. You can shower with it, and it basically records your heart rhythm every day for 14 days. I'll point out your heart beats 100,000 times a day, so quite a bit. And the patch is peeled off and sent back in. We're surveying for atrial fibrillation because the presence of it portends an increased risk of stroke. And in any patient where we find meaningful episodes of atrial fibrillation, measured usually in a few minutes a day, for example, we will initiate anticoagulation. Usually nowadays, we'll initiate anticoagulation with what's called a novel, I'm not sure they're so novel anymore, but oral anticoagulant, drugs like Eliquis, apixaban is the other name, rivaroxaban, Xarelto, and so forth. There are patients who also rarely nowadays choose to take Coumadin, but in our experience, both agents are equally effective. And in fact, the novel anticoagulants may be easier to tolerate. So we're very—
You moved away from warfarin.
Yeah, we're very aggressive at surveying for atrial fibrillation. There is such a high thrombotic event rate, or prevalence, that is clots inside, for example, the heart and the atrium in particular, in amyloid patients, even in the absence of atrial fibrillation. So we've seen patients who had demonstrated clots, for example, when they undergo what's called a transesophageal echocardiogram. For some reason, they're in normal rhythm, but there's a clot inside the heart. And that high prevalence of clots inside the heart, even when you're in sinus rhythm, has prompted many of us to try to look at what we call atrial function. So on the echocardiogram, as I was describing before, the top part of the heart, the atrium, contracts into the ventricle, and you can analyze how strong your atrium is contracting and moving. There are various techniques that cardiologists can do, and there's some, I wouldn't say consensus, but some interest in the cardiovascular community at even initiating anticoagulation in patients with AL amyloid who are in sinus rhythm when they have poor atrial function. Because if your atrium is still contracting normally, but barely contracting, it's kind of the same as if it were an atrial fibrillation and wiggling. And so those patients are the ones we believe have a high tendency to clot. And to be honest, a stroke is such a devastating event that everyone's so fearful of. Most patients, in what we call a context of shared decision-making, hearing this, usually opt, if the risks and benefits are favorable, to take an anticoagulant. So I think it's really a very important aspect of cardiac AL management, is surveillance for atrial fibrillation and anticoagulation.
One last question, not that this is super common, but what kind of medicines do you use to control high blood pressure in patients with amyloidosis?
Yeah, it's a good question. Thankfully, it's not that common. I would say if your blood pressure is high, that's usually a marker of the fact that your cardiac function is pretty good. It can generate a stroke volume and generate high blood pressure. in general, many patients who have cardiac involvement with amyloid are also concomitantly on diuretics that can be an antihypertensive. If they have proteinuria and not significant renal insufficiency or a high potassium, we often lead with what we call ACE inhibitors and or angiotensin receptor blockers. Those are kind of early standard medicines. We often encourage patients to avoid, especially if they have significant cardiac involvement. They usually don't have high blood pressure, but avoid drugs such as beta blockers because they reduce your heart rate. And in amyloid, your heart can't pump a lot every beat, so it needs to go faster. And a beta blocker usually exacerbates symptoms, especially high dose. And we strongly recommend that what we call non-dihydropyridine, that's a fancy word, but certain types of calcium channel blockers, particularly verapamil, cardizem, are avoided because those are agents that can bind avidly to the amyloid fibrils and cause high degree heart block and shock. And so we've seen patients who inappropriately received those medicines and got acutely much worse.
Can you give me the name of other calcium channel blockers besides cardizem that should be avoided?
Yeah, I said verapamil and cardizem are the two main ones to be avoided. Norvasc, which is a different agent, is probably acceptable.
Could you also mention beta blockers that you try to avoid? Could you tell me some names of beta blockers, generic in trade, please?
Yeah, metoprolol or toprol is a commonly used beta blocker. Propranolol or Inderol is another commonly used beta blocker, and carvedilol or Coreg and bisoprolol, all commonly used beta blockers.
Which you try to avoid?
Yes.
Okay, one more question, sorry.
Okay.
What about exercise? I have amyloid. Can you tell me about the safety of exercise, what I can do, what I shouldn't do?
Yeah, well, in general, I would strongly encourage you to exercise. I mean, I say to patients all the time that one way to make your overall physical fitness better, even if your heart's not functioning, is to compensate by making your rest of your body stronger. That is, your skeletal muscles, your blood vessels react better. So exercise is very important. In patients with AL amyloid, they often have, as we heard, some degree of damage to the automatic or autonomic nervous system. Accordingly, their ability to respond to physiological stresses like exercise are sometimes limited. They can't constrict their blood vessels quickly or dilate them as well. They can't alter their heart rate. So the key, I think, is to have what I would call a long warm up and a long cool down. Those of you who like to go to the gym in the past and run to the gym for 20 minutes, spending 3 minutes warming up and 3 minutes cooling down, that is the vulnerable time periods are when you're immediately exercising and when you're stopping exercise. So I usually instruct patients to think, if you want to exercise, say for 15 minutes, you should have, to the extreme, a 15-minute warm up and a 15-minute cool down, because those vulnerable periods are the time where you could get dizzy, lightheaded, or God forbid, pass out. And listen to your body. You know, if you're not feeling well during exercise, it's usually not damaging in the long term, but relax and stop exercising.
Can I shovel snow?
I would not recommend shoveling snow. That's what we call an isometric exercise. So it's like bearing down when you go to the bathroom or when you lift a heavy weight from the shovel, or a weight, you know, like bench pressing, and that increases the pressure inside your aorta and makes your heart have to pump against a much higher pressure, which makes the heart work harder. So aerobic exercise is much preferred to resistance exercise, though resistance is fine. If you're going to do it, you have to use very light weights, i.e. 5 pounds or less, but repetitively.
Thank you. Muriel, you're going to have Steve come over and shovel my snow.
I have a question. You brought up blood thinners, and we've seen a lot of questions in our Facebook group in the COVID-19 vaccine. People are questioning whether it contains a blood thinner. I don't know why they're questioning that, but what would be their concern about that? And is there some sort of blood thinner in the COVID-19 vaccine?
Dr. Paner?
I believe there isn't. I actually specifically looked at the ingredients because of certain allergies my patients have. I did not see any blood thinner in that vaccine.
So that's a myth.
Yeah, I'm not sure what they were referring to, Muriel. There's definitely no blood thinner in a vaccine. There are, described serious cases of COVID, particularly, God forbid, in the ICU, that have been accompanied by thrombotic events. And there's a high rate of thrombosis, clots,
Blood clots,
in patients who have COVID. And there's some interest, especially in the cardiovascular God forbid you have severe COVID, at initiating an anticoagulant such as intravenous heparin during those circumstances. That may be what the question is referring to.
Thank you.
I have a question for all of our hematologists. We'll go serially, starting, I think, with Dr. Zonder. Once patient achieves a complete hematologic response, what's a typical maintenance schedule for chemotherapy?
That is a wide open question right now. Until the Andromeda study, the typical maintenance for bortezomib or alkylator, which is the cytoxan melphalan family, the typical maintenance was no maintenance. Therapy was finite. The only drug class that really historically we've tended to use as maintenance is IMiDs. When they're tolerated, we tend to continue them. The biggest problem, as we've already heard, is that drugs in that class, the pomalidomide, lenalidomide, thalidomide family, is that those are not the easiest drugs to tolerate for many amyloid patients. And so even if started with the intention to do maintenance, a lot of patients end up having finite therapy, even with those drugs. Now, the Andromeda study changes this. It introduced the idea of daratumumab maintenance. And I should say, in fairness, that Dara is another drug because it tends to be well tolerated. Most of us who are using single agent daratumumab as salvage therapy, a lot of people continue it. When it hits it goes from weekly to every other week to monthly. And then when you're on a monthly schedule with very few side effects and it's working, I think clinicians and patients are, very inclined to continue it. What we don't know is whether that's necessary or not. We now have data that shows that daratumumab maintenance compared to a regimen that never contained daratumumab, including maintenance, is superior. We don't know if, we haven't proved beyond a shadow of a doubt that continuing Dara, if you started with Dara Cybor D and got a deep response, would that be enough to coast on? Do you need the maintenance? We don't know that. But again, just based on randomized data, if you're going to, if you believe the Andromeda data, if you want to follow what was done in that study, you're adding Dara as part of the initial combination, and then you're following it with Dara maintenance, and that probably probably establishes it as a standard maintenance strategy for newly diagnosed patients.
Dr. Liedtke, how do you approach maintenance?
Yeah, maintenance in amyloidosis is really a data-free zone. We know, of course, from the myeloma trials that keeping patients on maintenance prolongs progression-free survival, if not maybe overall survival. So one could be tempted to say, let's extrapolate that data to the amyloidosis patients. Or one could say, there is no data on amyloidosis, so we shouldn't do it. So I think what that boils down to is that it needs to be an individualized approach that's discussed with each patient. And there are certainly situations where I think longer term treatment or maintenance can be of benefit, especially in a patient who, let's say, has had multiple prior lines of therapy and we're not able to control the disease. And finally, we put them on a drug that controls the disease, then I would be much more inclined to keep the patient on that regimen, especially if it's not very toxic. The other thing that I usually wait for before talking about stopping therapy is some form of organ response. I want to make sure that the hematologic response that I've achieved is deep enough to allow an organ response. And that's, again, always in the context of toxicity. If the treatment is too toxic, then you would switch to something else. We have some limited experience with daratumumab specifically, where we looked at of the patients we've treated with daratumumab in a relapse setting. About, I want to say, maybe 15 to 20 of patients came off for reasons other than disease progression or lack of response. And we compared the time to next treatment for that small patient group to the time to next treatment for patients who remained on the daratumumab, and there was no difference. And a few patients who relapsed off daratumumab were retreated with it and they responded again, but these are very, very small numbers. So it's difficult to come to conclusions, but it's definitely, at least in the context of the small numbers, reassuring.
Dr. Paner, maintenance therapy?
Right, so I concur with Dr. Zonder and Dr. Liedtke. The only subgroup of patient I would highlight that maintenance could have a value if patients have multiple myeloma with secondary amyloidosis. So I'm going to guess that perhaps the patient who asked that question may be in that category. So in those patients, unfortunately, we have to mesh therapies that are tailored to amyloid and multiple myeloma. They are this unfortunate category where they can't enroll neither into myeloma studies nor amyloid studies, and boils down to a lot of common sense and creativity treating those patients.
Dr. D'Souza, can you tell me from your own data files what fraction of transplanted patients end up on maintenance therapy?
In most of my patients, I don't do maintenance after transplant for amyloidosis unless, as mentioned by others, if they also have multiple myeloma or other markers that suggest shorter time after transplant where we see a response. The one caveat is that there is this concept of consolidation therapy after transplant where if we don't see a complete response, and by that I mean complete hematologic response, we tend to use some chemotherapy at the back end, so around 2 to 3 months post-transplant for a short period of time, which might be 3 to 6 months, where we try and deepen the response that we have achieved with transplant. So in that setting, it's not really maintenance therapy, but rather modifying treatment to deepen hematologic response. I might consider that.
Thank you. I have a neuropathy question for Dr. Karam, if I could. It's actually a two-part question. One, how do you distinguish bortezomib neuropathy from amyloid neuropathy? The second question is, do you think intravenous immunoglobulin works for amyloid neuropathy?
Wow, these are great questions. So first of all, it sometimes can be difficult. But what I try to focus on, and it can be difficult for the patient to remember exactly what's happened, what came first. But obviously, is the patient start having neuropathy prior to the bortezomib, then it is very likely that this was related to the amyloid. And if the patient never had neuropathy prior to the bortezomib and started the bortezomib and then developed the neuropathy, then it's also clearly it's the bortezomib cause. Now, sometimes patients have both, and it can be difficult to really differentiate the two. When I get worried is when a neuropathy is progressing, meaning that the patient are getting weaker as they are thought or felt to be in remission. That could be an indication that they're actually not, and they may require additional therapy. So that is for the first question. For the second question, IVIG is a great drug for autoimmune neuropathy, such as chronic inflammatory demyelinating polyneuropathy. The neuropathy in AL amyloidosis is usually toxic, either because of the amyloid or because of the chemotherapy. So in those two conditions, IVIG would not be helpful.
Dr. Liedtke, in your previously treated cohort that had been exposed to daratumumab, does it stop working in patients? If it does stop working, what's the average duration of benefit? Do you keep them on it indefinitely? I mean, we've been very excited about daratumumab, but I think the question is, does daratumumab allow us to declare victory and go home? What are the expectations going forward, ongoing with daratumumab?
Yeah, so, with all of this, I think we have to keep in mind that the patient numbers that we've observed are relatively small. So you have to be very careful with making strong statements, but we have continued daratumumab therapy in many patients, mostly based on the idea that they weren't responding to anything else. And we finally found a drug that they're responding to, and it is very well tolerated. And so it's almost by patient choice that patients were continued. The response to daratumumab, usually if it happens very fast. So if you have somebody on it who hasn't responded within a short time period, then I think it's not likely that somebody will respond later. But if somebody has responded, then the responses tend to be long lasting. And I think with our follow-up being relatively long, I think the duration of benefit is certainly over a year, maybe approaching close to 2 years. Ultimately, patients can stop responding to daratumumab, of course, and that may have something to do with the plasma cells no longer expressing the target. That's at least one possible mechanism of resistance. And then as I said, we've had other patients who came off daratumumab therapy for various reasons that may have been either infections, where we felt maybe we were putting the patient at too much risk, or just by choice. And when we retreated them, they responded again. But again, these are small patient numbers. So I do think that daratumumab really is a major advance in the treatment of our patients with AL amyloidosis. But I don't think that that it's sort of the final answer, and that we definitely can't say that we're curing the hematologic disease and it's completely gone. I don't think that that's the case. It's just very well controlled.
And so recognizing that your population may be different from other populations, in your lengthy experience, it's fair to say that in about roughly half of the patients, the daratumumab may stop working after 2 years.
Yes, I think that sounds about right. Mm-hmm.
So yeah, we're not ready to declare victory and go home.
I have a question. We're hearing the term maintenance, and what we're seeing sometimes, and this is especially true in our Facebook group, is people say they're on maintenance and yet their light chains are elevated. That would be considered more a treatment rather than maintenance, would it not? I mean, I think we need the definition of what would be maintenance and what would be treatment, and what is Dr. Zonder brought up the term salvage therapy, and I think our patients would like to hear what is salvage therapy as well.
Go ahead, Dr. Zonder. What is maintenance? What's consolidation? What's salvage?
Well, maintenance therapy, the idea of maintenance therapy is to extend a response that you're satisfied with, after some prior more intensive therapy. Most people would define a maintenance regimen as a less intensive, long-term, often open-ended therapy that's designed to prevent a relapse from a prior therapy. Sometimes in very advanced disease, the best response you can get is not a response that we would normally be satisfied with newly diagnosed disease. But when we're talking about patients getting first or second line therapy, I think you hit it right on the head. I mean, usually we're thinking about continuing some form of more intensive therapy. And if we're really dissatisfied with the response, that's what consolidation or salvage therapy is for. I mean, consolidation, is therapy that's used to try and deepen a response that you're not satisfied with. The patient hasn't progressed, but haven't achieved what you consider to be a maximal response. Salvage therapy is for somebody whose disease has started showing evidence of progression. I mean, these are loose definitions, and people may quibble about the definitions, but in general, consolidation and salvage both refer to the utilization of full intensity, often combination regimens. And maintenance is something less than that, and it's given with different intention.
Thank you. Dr. Paner, this is a little bit difficult, and we can share this with our other speakers. But one individual says, I've noticed a cognitive decline in my husband. Is this a side effect of Pomalyst or pomalidomide, or is this part of the disease?
Well, that would be a key question to try to figure out in the clinic. It could be both, and it may not be easy to tell them apart because there is no test that would prove it's from pomalidomide other than stopping the drug and seeing symptoms get better. Pomalidomide can have a sedative effect, especially in people with renal impairment, elderly. I noticed that they are more susceptible to that sedative effect. And perhaps that could be perceived as a cognitive decline, but before you attribute anything to the drug, you really need to do thorough workup to exclude all the other possible causes, especially if the drug is working and well tolerated otherwise.
Dr. Karam, are you being referred patients with cognitive decline in the amyloid setting to try and sort through what's going on? And if so, how do you go about it?
So I don't typically specialize in cognitive disorder. I specialize in peripheral neuropathies. But that's a great question. And, you know, a lot of the medication that we give people other than the chemotherapy, for example, if you're giving them for pain, for neuropathy, that can cause cognitive decline. So I think important to review the medication, plus, do reversible, some workup for cognitive decline. B12 deficiency, which is common, can give you cognitive issues, a thyroid problem. And then, of course, if the patient has cardiac complication, you want to make sure they didn't have a small stroke or bleed in the brain that can also look at that. So definitely having a thorough neurological evaluation, looking at the drugs that the patient is taking, doing some blood work that can cause cognitive decline, and maybe some imaging of the brain are going to be helpful to make sure we don't have something we can treat.
Thank you very much. This is Dr. Liedtke. So here's one. Is amyloidosis linked to hearing loss or clarity of speech recognition? Does it damage the cochlea or the auditory nerves? How do we manage loss of word recognition related to the disease?
I'm not aware that that the disease itself affects hearing, even though, I mean, you can have amyloid deposition in pretty much any tissue. So conceivably, if there's any deposition in the auditory canal or anywhere in the ear that could potentially be seen. I personally haven't seen this, but it should be, if there's a concern for it, it would be appropriate to have that worked out by an ENT specialist.
Thank you.
Actually, we have published a case report where a patient presented with bilateral ear canal amyloid tumors as the main presenting symptom.
I've seen it once in 35 years where there actually were obstructing amyloid things. It's not very common. So yeah, Dr. D'Souza, here's something that I totally forgot about, but is important. My current therapy includes Bendamustine, and this has reduced my light chains by 80% in several months. What is the durability of Bendamustine when added to bortezomib, Daratumumab? Tell me what Bendamustine is and how it's given and how often it's given and where it fits in all these treatments. And if a patient is failed multiple therapies but hasn't received Bendamustine, is it worth a try? That's a lot. Go ahead.
Yeah, so Bendamustine is a alkylator drug. So it is from the same class of drugs as cyclophosphamide or Cytoxan that we use in Cybordi, or melphalan that we use in stem cell transplant. And this is a really good drug. It was developed in East Germany, and we got access to it in the 90s, early 2000s, and it's actually very well studied in some kinds of lymphomas, and it's kind of our standard of care in treating these lymphoma type of blood cancers. In plasma cell neoplasms, it's not as well studied, but there are trials that have tried to understand the role of Bendamustine in both multiple myeloma as well as amyloidosis. And just this past year, there was a clinical trial that was led by Dr. Lensch from Columbia University, where they tried using Bendamustine with Dexamethasone in patients who had relapsed amyloidosis. And there is prior data from Italy where they have tried using Bendamustine with prednisone. And what these studies showed is that it can be given. It does cause responses in about 30 to 40% of patients. It's generally given on days 1 and 2 out of a 4-week cycle. So in a month, you would have to come to the clinic or the infusion center on 2 back-to-back days to get the drug. One of the big side effects of this chemotherapy is that it can cause bone marrow suppression. So your white blood cell count, hemoglobin, platelets can drop, which is why in some patients we give growth factors or drugs like Neupogen or Neulasta on the day after the second dose of Bendamustine. And that can be a challenge in terms of long-term use of this drug. So the more you give it, you can cause severe myelosuppression or bone marrow suppression, and that can limit for how long you can give this agent. In general, when I've used this drug in amyloidosis, I've tried to limit it as a single agent, so just Bendamustine with Dexamethasone, although there are data out there that we can combine it with other agents like lenalidomide or pomalidomide, or even drugs like bortezomib. But again, when you add more agents to Bendamustine, you can make the myelosuppression or bone marrow suppression worse.
Does anyone in the hematology group want to comment on the side effects of Bendamustine? Jeff?
Yeah, I mean, I
Professor
can.
Zonder.
I mean, yeah, I can. Bendamustine, the side effect profile is actually, as Dr. D'Souza said, it's very similar to other alkylating agents. Myelosuppression or low blood counts is definitely the most pronounced issue with the drug, and especially since it's often used in a relapsed setting. And so the patients who are getting it generally have had more therapy. Most of them have had some form of alkylator-based therapy previously. So I agree. I tend to use it with steroids. In amyloid, I rarely combine it with other agents, even though there is data in myeloma that you can do that. There is also, there's, like with many chemotherapy drugs, there's some GI side effects. There's also rash, can be seen in a sizable percentage of patients, although it's not usually like dose limiting. Most patients don't have to discontinue because of rash, but it is actually a fairly common side effect of this drug.
Nausea, vomiting, hair loss?
Hair loss, no. No, yeah.
Nausea, vomiting?
Not much.
Also no.
Yeah, it's actually, of all of these drugs that we mentioned, the alkylators, nausea and vomiting is potentially a side effect of any of them. It's most pronounced with high dose melphalan, but with standard dose melphalan, with standard dose Cytoxan given as part of Cyborg-D, with Bendamustine as given, it's usually extremely manageable. That does not tend to be one of the worst side effects of these drugs.
Thank you. I want to spend the last couple minutes about the monitoring, because there were some important reports from Andromeda, as well as the clinician's experience here, because the doctors seem to focus a lot on the light chain ratio. And a lot of you have been talking about the difference between the involved and uninvolved light chain. And Dr. Paner, can you tell me what you're tracking to talk to these patients about how they're doing?
So, first you have to focus on a difference in the light chains, because you're really aiming for your very good partial response. You want to bring down that difference to less than 40 milligrams per liter. If you got lucky and you got there, then you can hope to achieve complete response. And that's where the ratio becomes important. And also immunofixation should show no heavy chain monoclonal protein. So with Daratumumab, actually, the CR rates in Andromeda study were pretty high. But in general, very good partial responses is what we've mostly been aiming for in amyloidosis in the past.
Dr. Liedtke, ratio or difference in light chains?
the primary number that we follow is the difference.
Agree, Dr. D'Souza?
Agree, difference.
So this is a big deal here, again, for our audience, that the experts in this panel are not following the ratio. They're not looking at the ratio serially because it will drive them crazy. And it's not as well validated as just subtracting the uninvolved from the involved. So if you're lambda, it's lambda minus kappa. If you're kappa, it's kappa minus lambda for the tracking and making assessments, or just looking if the uninvolved is a very, very small number. It's almost the same as just looking at the involved light chain over time. Muriel, are there any other burning questions in the last 5 minutes, or do you want to take over, have a bio break, shift? What do you want to do?
Well, I just want to mention one thing that came up when you were discussing bendamustine. When it first, appeared on the scene, at least my scene, I remember that it was used a lot with people that had Waldenstrom's or other type of non-Hodgkin's lymphoma. And we saw a lot of patients, well, a lot, in amyloidosis. We saw patients with Waldenstrom's getting bendamustine, getting Rituxan, and it seemed to have a wonderful response. So perhaps, so now we have expanded this beyond the Waldenstrom's. This is a question to people with AL amyloidosis. What is this when all else it has been tried, and then is that something then you go in for with the bendamustine? Is that what's happening there?
I think I'll pick that up because I do a fair number of Waldenstrom's patients, and I'll make a couple comments. Number one, exactly where bendamustine fits in with the half a dozen other treatments we've talked isn't very clear. But what we've heard from our panelists is that this is an agent that works. So people who are being told we have nothing further to treat you with, you should go on palliative care, and have never seen bendamustine, that may not be the right answer. Number two, the way I do it, and this is just a very personal thing, is we've heard our panelists say they give it for 2 consecutive days every 28, and actually I don't. I've learned that these patients with all their prior therapy, I give it 1 day every 28, and I don't bother with the second day. That may be good for people with chronic lymphatic leukemia, but I think the fragile amyloid population, I give it 1 day every 28, and after 2 or 3 treatments, if I'm not having problems, I might consider adding a second day. But again, there are people in your audience who are focused, and once they get through Daratumumab or Pomalyst, there's nothing to be done. But we've heard people talk about venetoclax, we've talked about bendamustine, we've talked about isatuximab. So there's stuff out there. Dr. Paner very appropriately talks about bendamustine dose limitations with kidney failure. And I have to tell you that on the package labeling, it says you shouldn't give it in kidney failure. I've ignored that and just made major dose reductions. And I've given it to patients with creatinines of 5 and 6, because when you're dealing with a serious disease like amyloid, sometimes you bend those rules, but that can only come from experience. You're not going to get that by reading a textbook. She's right. And I will just tell you that 6% of amyloid patients have akin to Waldenstrom's, and we do use rituximab and bendamustine as primary, but that's only 6%. But that would be frontline treatment.
And we're going to be hearing about a new drug now after the break, which is pretty exciting for those people, as you say, where the doctor wants to put them on palliative care because they haven't tried everything. So it's good to know about bendamustine, and we'll be hearing about another new drug. But one more question I have for the group is dexamethasone. We've had quite a few people wondering, the doctors mentioned fluid overload or swelling, and yet we hear about some physicians treating just with dexamethasone for long periods of time, and we hear from our doctors that's wrong. I'd like to know why you don't like that, and also we hear from people just being treated they're on Cyber-D regimen, but they seem to be on a regimen that was designed for multiple myeloma with a very high amount, like 40 milligrams or more of dexamethasone. So can you comment on the amount of dexamethasone and just giving dexamethasone alone?
So those are great questions related. Dr. Paner, why don't you start about how you use dexamethasone in this disease?
Well, I did mention it's one of the hardest drugs to tolerate in plasma cell disorders. And I think there are now multiple studies that prove that less is more. You know, the only time where I still use high doses of dexamethasone is actually in multiple myeloma CAS nephropathy. That's where we go with 40 milligrams for 4 days on and off, or if it's truly the only drug that we can use to bridge patient till next effective therapy. In amyloidosis, again, I find that dexamethasone is even harder to tolerate, and I usually use it about 20 milligrams a week and try to dial down as possible once patients achieve response.
Dr. Liedtke, Dex.
Yeah, I agree. Dexamethasone is the drug that we reduce first, and I don't treat anybody with dexamethasone alone.
Dr. D'Souza?
Same in patients who have advanced stage or advanced cardiac amyloidosis. I often start at 20 and might even cut down further. So I've learned over the years to respect dexamethasone.
If I use dexamethasone, will I get more muscular?
The opposite.
Go ahead.
The opposite. You know, right. So it's not an anabolic steroid. It's not. You will not get more muscular. In fact, you get proximal muscle weakness in your arms and legs, and tend to get a redistribution of body weight from your limbs to your trunk, and so it's a patients often feel weaker, and that's one of the
Jeff, I can't hear you. Are your earpods out of juice?
Ooh. Can you
Better?
hear?
Yes, much better.
Morie, if I could just comment for a second also just about dexamethasone and diuretic dosing in patients with cardiac amyloid. So I agree with everything that's been said. We often ask our hematology colleagues to reduce the dexamethasone to the minimally necessary dose, ideally not more than 20 and preferably 10 or even less. But I think many patients are treated with loop diuretics, and not all loop diuretics. These include furosemide, otherwise known as Lasix, torsemide, otherwise known as Demodex, or Bumex, otherwise known as bumetanide, are not all equivalent. The latter two, that is torsemide and bumetanide, are loop diuretics that are quite potent like Lasix, but are much more bioavailable, which means they're better absorbed. And in many patients with amyloid who take furosemide or Lasix, which as the name implies, Lasix, it lasts 6 hours, they do not have an effective diuresis because Lasix is, again, poorly absorbed, especially through the gut wall when there's edema. So you could be taking 80 milligrams of Lasix a day, but absorb 8 milligrams or 16 milligrams, 10 or 20% gets absorbed and the rest does not. And it's highly ineffective. And so we often switch patients to torsemide or bumetanide, which is not only longer acting, it usually lasts 10 to 12 hours, causing a diuresis, but it is much more absorbed. And so that's an important change that's very simple to do, that if you're not on that kind of diuretic and you're feeling swollen or short of breath, you should certainly ask your oncologist or your cardiologist who's caring for you to consider the switch.
A very important point. I don't know one end of a diuretic from another, but our cardiologists insist that we use torsemide and not use furosemide. Dr. Zonder, we actually interrupted you.
No, I'm sorry. My headphones ran out of juice, so that's the problem with wireless technology.
Are you in
right?
Texas?
Yeah. So what I was starting to say before was that when I'm screening my patients for neurologic symptoms at their visits, something that for me is a red flag that we're actually dealing with a steroid complication rather than neurologic progression is that they have motor weakness in their limbs, especially if it's proximal, especially if it's like their hips, their shoulders, more than their grip or pushing down on a pedal. If they have that without progression of sensory findings, to me that's much more likely to be a steroid side effect than a Velcade or amyloid related side effect. And so, I will generally I will hold steroid initially and then, or at the least reduce it in such patients to see if there's improvement. In our practice, I follow the same guidelines that Dr. D'Souza mentioned about advanced stage, fluid retention, known cardiac involvement. You have to start with a lower dose of dexamethasone. But even doing that, even if you follow sort of guidance that you use a reduced dose of 20 milligrams in those patients, half or more of patients are going to need further dose reduction over the course of their therapy.
So for the audience, you've heard the global experts in this disease say it's rare for them to use 10 pills a week of dexamethasone. They're not giving 10 pills a week. They're giving 5 pills a week or 3 pills a week, and are maybe looking longer term to just get rid of it completely because it is a tough medication. Muriel, turning it back to you.
Okay, great. It's now 1:06 by my clock.
Yeah, what's for lunch?
Well, what did you order? So what we're going to do, is we're going to have more Q&A. We're going to hear about the new drug from Dr. Royal, and we're going to hear from Dr. Wall, and we're going to hear from Paula. So we got a lot happening, but we've got to take a 10-minute break. You do understand?